Hello, everyone, and welcome to the Lung Cancer Coalition, another webinar in our series. We're so glad that you can join us today. We are the Maine Lung Cancer Coalition, and we are truly working together to reduce lung cancer in Maine. Next slide. For funding today, we are funded by the Bristol Myers Squibb Foundation, the Maine Cancer Foundation, and the Maine Economic Improvement Fund. Today, our webinar is titled Shared Decision Making and Lung Cancer Screening, and we are so happy today to have Dr. Paul Hahn and Dr. Neil Corson here to join us as our presenters. So just some few housekeeping things that we usually go over for these webinars. For logistics, the audio lines for non-presenters for all of you are currently muted. Please use the chat box for any questions that you have or any comments throughout the presentation. Typically what we do is we will look at the chat box and we will answer those at the end of the presentation. If you are requesting CME for this webinar or you did not sign in to Zoom through a direct link, or if you're watching as part of a group, please email us here at mlcc@mainequalitycounts.org. During the presentation, you can do it in the chat box or immediately after, so we can track your participation and make sure that you get the follow-up survey and then your CMEs as well. QC staff, we work together to improve the health of everyone in Maine. And again, we are Maine Quality Counts. You can connect with us at mainequalitycounts.org and through various social media sites, as you can see below. So for today, for speaker disclosure, and again for the CME certificates, for CME disclosure, the speakers today do not have any relevant financial relationships with the manufacturers of any commercial products and or provider of commercial services discussed in this CME activity. Again, like I just mentioned, a CME evaluation survey will be sent to each of you after the learning session via email. Again, why it's very important to let us know if there's more than one of you viewing at a certain location. And you want to complete that within a week of the please, if you could please complete the survey within 1 week, and again, then we will send out a CME certificate within 1 month of completion of the survey. So today, for the presenters, again, I'm so pleased to have Dr. Paul Hahn and Dr. Neil Corson with us today. Dr. Corson is the co-lead of the Maine Lung Cancer Foundation, Lung Cancer Coalition. He is a physician scientist at the Center of Outcomes and Research and Evaluation at Maine Medical Center. His research experience includes work on depression and primary care, behavioral health integration, shared decision-making, and practice redesign. Dr. Corson has spent almost 20 years as a family physician and geriatrician in rural Maine. He returned to school and graduated from the master's program at the Center for the Evaluative Clinical Sciences at Dartmouth, now the Dartmouth Institute, in 2002. And again, we are also very happy to have Dr. Paul Hahn. He's the director of the Center for Outcomes and Research and Evaluation, also known as CORE at Maine Medical Center, and associate professor of medicine at Tufts University School of Medicine. He's a health services researcher, a general internist, and a palliative care physician. He is board certified in internal medicine and hospice and palliative medicine, and received an MD at New York University School of Medicine and an MA in bioethics and an MPH from the University of Pittsburgh. He completed internal medicine residency at UCLA and fellowship in cancer prevention and control at the National Cancer Institute, also known as NCI, at NIH. So again, we are so glad to have you both with us. And at this point, I'm going to turn this presentation over to them. Thank you so much.
Great. So on behalf of the Maine Lung Cancer Coalition, I just want to thank Quality Counts and Jessica for hosting this webinar series, and we're very excited and pleased and honored to be able to share some of the work that we're doing. And one of the things that is a critical component of lung cancer screening is shared decision making, and specifically the counseling that must happen before a patient undergoes screening with low-dose CT. And that's really going to be the focus of our webinar today. Next slide, please. So we've got really two objectives of this webinar. First, we are going to describe the evidence supporting lung cancer screening as a clinical preventive service, and to explain why shared decision-making is required as a part of the lung cancer screening program. And as part of that, we're really going to give you a broad overview of what shared decision-making is, what are the essential sorts of information needs to be transmitted during these consultation visits. Next slide, please. And just want to mention we have no financial conflicts to disclose. We are funded, as Jessica mentioned, by generous support from the Bristol Myers Squibb Foundation, the Maine Cancer Foundation, and the Maine Economic Improvement Fund. Next slide, please. So I want to first start the discussion really at somewhat of a high level and talking about what is shared decision making? What do we mean by that? And then we're going to get into defining not only the elements of shared decision making, but then what are some tools and approaches that can be used to foster shared decision making? And in particular, what is the tools that we call decision aids? And then thirdly, we're going to talk a little bit about one vital component of shared decision making, which is risk communication. And then we're going to review some evidence about the effectiveness of shared decision making. You know, what is the evidence that supports us doing this, and what are the effects of shared decision making on patient outcomes and care? And then finally, we're going to bring it back to the topic of lung cancer screening with low-dose CT, and how does shared decision making fit in with that? Next slide, please. So just to start really in presenting what really the North Star is with all of this effort, you know, how do we think about shared decision making, and what is it? There are many different definitions out there in the literature of what shared decision making is, but one way that we like to conceptualize it at a very high level is the way that Glenn Elwin and colleagues have talked about it. It's really a process of collaborative deliberation. And so there's two components to that. There's collaboration of a clinician with a patient working together to sort of figure out what the best options are in a given situation. And then there's deliberation. So that means this is thoughtfulness that we're really trying to inject into any decision about any clinical service. There's a couple of other definitions I've listed here that get more into the specifics of what goes into that collaborative deliberation. So you can see there's a definition that others have put forth, that it's when we can foster understanding of what a clinical service involves, including the benefits, risks, limitations, alternatives, and uncertainties. And then there's another nice definition there by Charles and colleagues. It's an interaction or an interactive process between a patient and a clinician that engages them, provides accurate information, and most importantly, tailors the treatment decision to the patient's own preferences and values. So these are basically three different ways of looking at this problem, but you can see that really they're saying the same thing, and it comes down to that collaborative deliberation and what are the sorts of things that we're trying to really optimize and maximize in these conversations. Next slide, please. So if that's a high-level definition of shared decision-making, when does it really need to happen? In what kinds of clinical circumstances does it apply? It's arguably applicable to really any clinical decision. But on the other hand, we think that it's most important for decisions where there's so-called clinical equipoise, that is, where there's more than one reasonable treatment option. And that could be either because the scientific evidence is maybe incomplete or conflicting or insufficient, or it could also mean, even in cases where there's good evidence, that the right decision really comes down to how a patient himself or herself values the potential outcomes of a decision and has to bring their own preferences to bear on that decision. And the ultimate goals of shared decision making are to really foster realistic, informed treatment expectations and care and decision making that's consistent with the patient's own values. Next slide, please. So how do we operationalize that? Those are sort of high-level ideals that we're trying to promote with shared decision making. What does it really mean in terms of concrete tasks? And here's a set of bullets here that really get to how do we put this into practice? What are the sort of key elements of an actual conversation? And I think that these few bullets do a good job of distilling that. And first of all, it's a matter of involving the patient in decision making. So letting them know that there's actually a decision to be made and there's more than one reasonable choice option. Secondly, it's to clarify what patients themselves understand. What is their level of pre-existing knowledge that they bring to the decision? Third, to provide information. And this is, again, we look at a couple of slides and bullets on this, but we want to talk about the nature of the condition, the medical condition itself. What are the interventions? What are the options for intervention? And then importantly, what are the benefits and the risks or harms of the intervention to the best that we know with available scientific evidence? And then also, what are the limitations of that evidence? What are the scientific uncertainties that apply to this situation? And then fourthly, eliciting and clarifying patient values. This is one of the most important things that, it's one thing to give information, but importantly, what we want patients to be able to do is then apply that information to the decision based on their own values and preferences. And then finally, to help the patient make a decision and to arrange follow-up for that decision. So these are really the key process elements of shared decision-making. Next slide. Here's a nice way to operationalize shared decision-making as a process. This is, again, a kind of a picture and a conceptual model put forth by Glenn Elwin and colleagues that really distills shared decision-making into three kinds of what he calls talk. There's team talk at the top of this figure. There's also option talk on the right-hand side, then decision talk. And the couple things that I want to point out, so team talk really means letting the patient know that we're working as a team to solve this problem because there's more than one option. There's actually a decision to be made. It's not necessarily straightforward. So we're aligning with the patient, partnering with them, building that collaboration. Option talk on the right-hand side is discussing the options, the alternatives, and the benefits and potential harms and the uncertainties around that option. And then moving to decision talk is where the clinician helps the patient integrate that information with their own values, helps them understand their own values and apply to the decision. In the middle, you'll see it says active listening and deliberation. Again, these are the sort of higher order processes that flow through the entire conduct of shared decision-making. And one thing I want to point out, which is especially nice about this model, is that it's a circle. So it's not a linear process where you necessarily go from 1 to 2 to 3 and then it's all over. There's a lot of revisiting and interaction between the clinician and the patient to solve these problems. And it may not happen in a nice linear fashion. But ultimately, what we're trying to achieve, again, is collaborative deliberation with this. Next slide, please. What we're going to talk about a lot today, if you could go back to that. So what we're going to talk about a lot today in the rest of the talk is option talk and talking about what are the alternatives vis-a-vis lung cancer screening. And a lot of what we're going to deal with is this, although I want to point out that these other types of talk and these other issues are equally important. It's just that we're going to dwell a little bit more on options and the information around that for the rest of the talk. Next slide, please. So how do we do that? How do we put that into practice? Well, it's one thing to sort of say we need to do a lot of different kinds of talk and we need to present a lot of information. That's a pretty tall order, especially in a short office visit. And luckily, though, there are tools out there that have been developed by several investigators and clinicians around the country. These tools can really help facilitate that process. And in particular, there's a type of intervention known as decision aids, which are tools that we can use in these conversations or even outside of conversations to help transmit information in an effective way to patients so that it can help them understand the potential benefits and harms and the uncertainties. It can help them even clarify their own values about a given medical intervention. And they're intended to complement rather than replace counseling by a clinician. Next slide, please. So we're just going to show you very quickly some examples, coming back to the specific example of lung cancer, of what do some of these tools look like. And you can see that they vary. They can be big or small, but some of them can be brochures or print decision aids. Some of them can be websites or online tools. This happens to be an online accessible, just print document put out by the American Cancer Society. Next slide, please. This is another example of a one-page decision tool that's been put out by the National Cancer Institute that tries to educate people about what was found from a large study of lung cancer screening in terms of different risks and benefits of low-dose CT used in the screening setting. Next slide, please. This is another type of tool that we think is very nice to use in the encounter between a clinician and patient. This is something developed by Elwin and colleagues called an option grid, which tries to lay out the issues that a patient needs to think about in a very simple, scannable way. And listing, if you can look at the left-hand side, posing some frequently asked questions using that format, then lining up the options in the other columns and helping patients understand, well, what's at stake if I choose option A versus option B? And in this case, that's low-dose CT screening versus no screening. It goes through the benefits and the harms and the potential outcomes. Next slide, please. And then here's another example of a decision aid that was put out by the Agency for Healthcare Research and Quality on low-dose CT screening for lung cancer. And I'm just showing you one screenshot of part of that decision aid where they're trying to use graphical representations of risk and benefit to help patients understand what are the potential risks and benefits of lung cancer screening. And again, I'm just flying through these to give you a sense of the fact that there are tools out there that can help with these encounters with shared decision-making conversations, but can even be sent to patients outside of encounters to help educate them about a given medical intervention, such as lung cancer screening. Next slide, please. So one essential component that I want to talk about and drill down a little bit more is the task of risk communication. You know, I've already showed you some screenshots and examples of decision support tools that try to present information about benefits and harms. This is a particularly challenging part of shared decision making. So we wanted to just spend a couple minutes on this in particular. Next slide, please. So coming back to this three-talk model of shared decision making, risk communication really fits into this option talk piece. And again, it's one of the more challenging tasks of shared decision making. It's not that it's more important than anything else. It just happens to be challenging for a number of reasons that we'll just talk about briefly. Next slide, please. So risk communication is really the communication of risk information, which is defined as the information about the probability of a future outcome. And I like this particular definition of risk communication, which describes it as an open, two-way exchange of information and opinion about risk, leading to better understanding and better decisions about clinical management. And what's important about that definition is that we're talking about an open and a two-way exchange. So it goes back and forth between a clinician and patient of not only information, but opinion about risk, because there can be different opinions about risk. And the idea is to help the patient understand what the objective evidence shows, but in the end, they have to, in a sense, subjectivize that risk. They have to decide how important or high or low that risk feels to them, how important it is in their decisions. Next slide, please. So the challenges of effective risk communication are really threefold. One is in numeracy, and this is really the sort of mathematical equivalent of illiteracy. And we know from many studies that the general public and patients in general, as well as some clinicians, have difficulty understanding and using numbers, and particularly understanding the concepts of probability and chance. So whenever we use risk information, talking about the probability of the future, those are intrinsically difficult concepts and figures for people to weigh and understand effectively. Secondly is what's known as heuristics and cognitive biases. And heuristics are really psychological or mental shortcuts that we rely on every day in our lives because we can't spend all our time calculating every little number and probability that comes before us. So we rely on a lot of rules of thumb that are often adaptive, but they can also lead to errors in our judgment. And cognitive biases are the same way. They're sort of hardwired errors in thinking that we find difficult to escape because it's just the way our brains work. So it subjects us to cognitive illusions when we think about probabilities and chance and statistics. And thirdly is the fact that, as I mentioned before, risk is inherently a subjective construct. We can talk about evidence and how many people in a population will suffer a certain side effect, for example, or be benefited by lung cancer screening. But when it comes down to what will happen to that individual person, we're no longer in the realm of simple evidence about a population. that person is left with deciding what they feel their own chances are. And there's not a scientific answer to that. Next slide, please. So for example, if we asked people, just took a random sample of people and gave them some qualitative terms like, your chances of benefiting from screening are rare, or they're unlikely, or they're probable, or they're very likely. We asked them to put a number on what those different qualitative terms meant, it would be all over the map. And that's because people judge and weigh risks differently. So what I think is a rare risk is going to be different than what somebody else thinks is a rare risk, and might even approximate what they think is a very likely chance of something happening. So it's inherently subjective, and that makes risk and risk communication very difficult. Next slide, please. So there's a few best practices, though, that one can derive from the literature, and also a lot of evidence on how people process risk information. And some of these may seem very intuitive and basic, but I would also venture to guess that many of us struggle with actually conducting risk communication efforts in a way that adheres to these best practices. And one is to use plain language and to minimize computation. So whenever we talk about risk information to somebody, minimizing the arithmetic that they have to do and trying to present things in plain terms. Some of this means, you know, instead of using figures like, well, 1 in 278 people will suffer this side effect. That's very hard when you use odd denominators like that. So it's better to just use simple denominators, whole denominators like 10 or 100 or 1,000, and express things in terms of frequencies or percents like that instead of using the sort of 1 in X type of format. And then secondly is to help people distill the gist. So if we lay a lot of numbers on somebody and just walk away and have them have to figure that out, that's less preferable to us sort of saying, well, you know, this seems like a relatively smaller risk than this other risk, and even putting into context and comparing it to risks of common occurrences in everyday life. Thirdly, this is one of the most important things on this slide, that when we communicate risk, we want to be neutral. We don't want to push a patient in either direction. We want to have them make an informed decision of their own. And we know that how we frame the information can actually bias people's judgment. So if we talk, for example, in terms of a 10% chance of dying versus a 90% chance of surviving, we know that if you present it in only one way, you're going to get different judgments and decisions, because we know that the chance of dying is scary. So if you framed it in terms of a 90% chance of living, you're going to get a different type of response from a patient. So we think that using positive and negative frames both to neutralize that type of framing effect is important, as well as using both absolute and relative risk reduction to talk about the benefits or harms of an intervention. And then finally, visual or graphical displays can be helpful, like the one I showed you from the AHRQ. Although some of you might have looked at that and actually found it confusing, and we've done studies where we have found that they are confusing to patients. So even when we use graphical displays like that, they need to be explained, you know, to patients. Next slide, please. So now I'm going to turn the talk over to my colleague, Dr. Neil Corson, who's going to address the issue of what the evidence is around decision-making and shared decision-making. Thank you.
Thank you, Paul. Excuse our smooth transition here. So we're going to talk a little bit about the research on shared decision-making, just to give you a sense. What this really comes down to is a very common comment that both Paul and I receive when we teach about shared decision-making, which is, oh yeah, I already do that. So because it would require us to be in the exam room with any of you listening to know whether you do or not, we're not going to debate that point, but what we want to do is talk a little about what the literature says is happening in decision making, and then talk a little bit more about our sense of what may be different between shared decision making as it was just described and what happens in clinical settings. So next slide, please. Thank you. Probably one of the most important sources of information about shared decision-making have been the Cochrane reviews. Cochrane reviews are a voluntary process performed by people around the world, generally people who are skilled in statistics and epidemiology, who use very high quality methods to review the literature on many topics. The Cochrane collaboration publishes their reviews. They're available on the web. And they have reviewed the issue of shared decision-making and decision aid use multiple times in the last 10 years. They will revisit a topic when there's enough new research that they need to review it again. And in the last 10 years, I think they've done at least 3 reviews of decision aid use. So what has been consistently found, the most recent review was now about 4 years ago, is that the use of decision aids to support shared decision making leads to better decisions. And so the first 5 bullets on this list are referred to as decision quality measures. Things like patients have more knowledge about the decision and about their options. They're more accurate in their perception of their risk based on whatever the decision they're facing is. They're more comfortable with the decisions they've made. They're more involved in the decision-making process, and they're less likely to be undecided. So all of those together are described as decision quality measures, and it's been well demonstrated that shared decision-making using decision aids improves decision quality. The last bullet is the most controversial and one that I think we still don't know the answer to. There's been hopefulness because of some research out there that using shared decision-making, patients tend to choose less aggressive, less invasive, and less expensive approaches to care. And in particular, when shared decision-making about elective surgical procedures has been studied, there's been hopefulness that well-informed patients will be less likely to choose elective surgery. That hopefulness is really tied to our need to decrease the cost of care in the current environment. So there have been now enough short-term studies of these choices regarding surgery that the Cochrane review can now conclude that less people choose major surgery in the short term. And I'm emphasizing that on purpose, because what we don't know is people who might decide now not to have a knee or hip replacement, what will happen in 5 or 10 years as their disease process progresses, and will they choose surgery at a time that they're older, sicker, and therefore the cost may be higher. So even though we know it looks as though shared decision-making does decrease people's choices about having surgery or not in the short run, we really don't yet know enough to know what impact that will have on cost of care in the longer run. So that's one important source of evidence on shared decision-making. Next slide, please. There are a few other studies that I think are worth mentioning, and I'm going to go over in some detail now. The decision study was published roughly 10 years ago. It was a patient survey study, and patients were first asked if over the last 12 months they had made any of the 10 decisions that you can see listed below. Decisions about cancer screening. This was before lung cancer screening had been shown to be effective, and therefore that's not one of the decisions. also decisions about elective surgical procedures and medications. And anybody who said that, yes, they had made one of these decisions within the last 12 months was enrolled in the study, and they were surveyed about the decision-making process. So this was retrospective, and it was asking people to remember the decision-making process that might have happened almost a year ago. Next slide, please. So patients reported about the decision-making process that almost all of the time, the pros or the benefits of whatever the decision was were discussed, while less than half the time, the cons or the risks of the decisions for these interventions were discussed. That was not true in terms of the surgical decisions, presumably because if you're going to have a surgical intervention, you need to do informed consent, and informed consent requires that those discussions happen. The other thing that patients reported is that while almost all of the time the provider, the clinician, expressed their opinion of what the patient should do, less than half the time was the patient asked what they would like to do. So it appears that we're more likely to talk about the benefits than the harms of interventions. We're more likely to express our opinion than to ask the patient for theirs. Next slide, please. So if we're essentially substituting our perception for the patient's preference, then that would suggest that we need to be good at knowing what a patient would say in terms of what's important to them. So this study by a colleague, Karen Sapuka, who's at Mass General, also published about 10 years ago, looks at how good we are at predicting what's important to patients. So in this case, the decision to be made, these were women who had been diagnosed by mammogram and biopsy with early stage early stage breast cancer, and were asked whether they wanted to have a lumpectomy to remove just the part of the breast that has the cancer, or a mastectomy, which would remove the whole breast. So providers were asked, what are likely women's concerns? And you can see most providers thought that keeping the breast, living as long as possible, looking natural without clothes were the most important things, and the avoidance of prosthesis was not at all important. The next slide, though, shows what patients told the researchers, and you can see, next slide, please, that statistically we were off in every case, that we overestimated what some of the concerns would be and underestimated others. And this essentially suggests that we are not as good at predicting what's important to a patient as we could be, and therefore it's important to get the patient's goals and concerns out on the table using a shared decision-making process. Next slide, please. So one other study that's about 5 years old that we also think is interesting and important in terms of decision-making and challenges to shared decision-making. This is a study that was done in Palo Alto, California. Dominic Frosch works at Stanford, and did focus groups with patients in this relatively upscale community where patients are relatively well off financially, well educated. And what was found by talking to a group of almost 50 of these patients over a series of focus groups was that even these patients who we would assume are in the best position to feel comfortable questioning the doctor and having this kind of discussion felt some need to defer to the physician acknowledged, and I know that this may be surprising information for some of you, that physicians can be authoritarian in the way they interact with patients, and that the issue of being seen as difficult by asking questions was something that they considered risky because it might influence the care they received, and it might affect even these folks who are, you would think, very well prepared to have these conversations, would make them hold back from questioning their physician. So if we want to do shared decision making, it's very clear that we need to invite patients and make it safe and help them understand that we want them to be involved in the decision and we're going to help them do it. And Paul made some points about that earlier. Next slide, please. So let's talk about how all of this applies to the shared decision-making and counseling visit that's required by the Center for Medicare and Medicaid Services to pay for a low-dose CT scan for lung cancer screening. Next slide, please. So first of all, let's go over, if we were having a conversation with a patient about the pros and cons of lung cancer screening, what would the benefits be that we would want to talk about? Well, the most important, and the reason that this is now a recommended preventive service, is screening for lung cancer improves prognosis, reduces the mortality rate from lung cancer. We've presented the benefit in both the absolute risk reduction, which is out of 1,000 high-risk people screened, and at this point, lung cancer screening is recommended only for those who are at high risk. So out of those 1,000 people, 3 less people will die of lung cancer. That's a 20% relative risk reduction. One of the true, I would say, important benefits of lung cancer screening is it not only reduces the risk of dying of lung cancer, it reduces all-cause mortality. So it reduces your risk of dying from any cause. We think that's at least partly because screening with a low-dose CT scan may find other abnormalities that, if recognized and treated, can benefit the patient. So that there's 5 fewer deaths per 1,000 overall as a result of screening, which is a 6.7% overall relative risk reduction. And again, as I said, that has to do with finding other abnormalities that could benefit from treatment. Next slide, please. The reason that shared decision-making is required is there are, in addition to those potential benefits, also potential harms. One is there will be cancers that will be missed by screening. Even so, there are people who are not in the high-risk group who wouldn't be eligible for screening who may still get lung cancer. It's roughly 20% of lung cancer is in people who've never been smokers, which is the primary risk identified right now. So you may have a scan, have it look normal, but still have lung cancer. That's a false negative. There are, just as is true with other screening tests, specifically mammography for breast cancer and PSA for prostate cancer, there are false positives. And what that means is something abnormal will show up. That abnormality may look suspicious for cancer in a minimal or a rather substantial way, but in any case, those abnormalities will at the very least engender some worry in the patient, and we need to make sure they understand that those abnormalities are quite common, 223 out of 1,000, almost a quarter. For a subset of those, the ones that are the most suspicious, there will need to be, so for most of those 223, they'll be recommended to have another scan sooner than annually, which is the recommended frequency. And that's not at all unlike having to come back for some additional mammography views in women who are being screened for breast cancer. Some of these false positives will look suspicious enough that an additional study, a biopsy in particular, may be recommended. And a biopsy being an invasive procedure, there is always some risk. So roughly 18 out of 1,000 will need something more than a repeat scan, and a small percentage, about 2 out of that 18, in other words, 2 out of 1,000 might have a complication of the invasive procedure. There is also, and this is a challenging thing to understand, I think, especially by patients, some of the abnormalities that are seen, including some cancers, may be cancers that would never grow and would actually never threaten the life of the person being screened. Those are referred to as overdiagnosis. We believe that that is also true with regard to PSA screening. That's one of the reasons for the controversy. So this idea that we might find cancers that if left alone would never cause the patient any problem, the investigators who did the large national lung screening trial, which provided the evidence that led Medicare to approve payment for screening and led the U.S. Preventive Services Task Force to recommend screening, those investigators, in looking at their own data, estimate that it could be as many as 18% of the cancers diagnosed would never have caused the person any harm. It's really hard to know that. It's hard to prove a negative, but we do need to keep that in mind. The other thing is a low-dose CT scan, while it is low dose, still does have some radiation exposure. It's generally compared to the radiation that we all receive just by being alive and being in the world. And so the amount of radiation from a low-dose CT scan is about 6 months worth of background radiation. If you remember that screening low-dose CT scan is recommended annually and might even be done more often if false positive, if some sort of abnormality is seen, the amount of radiation exposure might add up over the years to somebody who starts being screened in their 50s and continues to be eligible into their 70s. Next slide, please. So just to focus in a little more on a couple of the decision aids that Paul showed earlier, this is a magnification of a small part of that option grid, which is the one that's set up with frequently asked questions down the left column. The answers in the middle are those if you are screened, and the ones on the right-hand column are if you're not screened. Just to give you an idea of how this decision aid, which was made, it could be used by a patient to prepare for this counseling visit, but it's also made to sit down with the clinician and the patient to look at the information together during what Paul referred to as the option talk. So you can see here how it talks about the benefits and the harms of screening, and you can see obviously if you're not screened, there's no benefit. And if you're not screened, the harms are that if you do have cancer and you wait until you're symptomatic, that likely means the cancer is at a stage when treatment is much less likely to be helpful. The next slide shows you the AHRQ icon display. So again, just to get a little deeper into this graphic way of showing the information, the icon display, each of them shows 1,000 little triangles. I think those are triangles. I have to put my glasses on. Or 1,000 little people to represent the denominator of 1,000 people who either get screened or do not get screened. The one on the right is the easiest to talk you through. Out of 1,000 people who meet the criteria to be screened, who are at high risk for developing lung cancer because of age and smoking history, 21 of those people on average will die of lung cancer. So if you're not screened, you have a 21 out of 1,000 chance of dying of lung cancer if you're in that high risk group. On the left are the data elements for what happens if you are screened. So the first thing you'll see at the top is 3 of the 21 icons that were outlined in orange are now outlined in red. So that is in purple. I do know what color that is. So the 3 in purple is that absolute risk reduction of 3 less people dying from lung cancer if they are screened. And the relative risk reduction, well, we won't get into that detail. I'll confuse myself and maybe others. You can also see, though, at the bottom, outlined in dark blue rather than light blue, are the 223 or so people. It looks like in here, actually, it's 300. I do need my glasses to read this one, excuse me. 356. So the 223 is the number of false positives from one screening. This is the number if people are screened annually for 3 years and then followed for another 3 to 4 years after that. So there will be actually over 350 false positives. And of those, 18 outlined in sort of light purple pink, who will need some sort of invasive follow-up, and perhaps one of those who will have a serious complication as a result. So the numbers don't quite match exactly the numbers we used earlier, but they're in the same ballpark. As Paul said, the gist is similar, that there is a measurable, relatively small benefit in terms of reduced lung cancer mortality, a relatively high number of false positives, most of which are nothing to be concerned about, a few of which will require an invasive procedure that might have a rare, I would say, rare complication. And again, this is a decision aid that's designed for a clinician and a patient with or without family members to sit and go over this so the patient understands objectively what those risks are and can then think about how they weigh those risks in relation to what's important to them. Next slide, please. So this is really, this has been one of the most challenging things as Paul and I have both been teaching about shared decision making. The question is, because Medicare requires you to say, I did shared decision making in order to pay for a low dose CT scan to screen for lung cancer. So the question is, how do we document that shared decision making happened? And I just want to talk briefly about that in our last few minutes. So next slide, please. Paul talked a little bit about this in terms of the process, and I think the process and the components line up nicely. So this is what we believe it means to say that shared decision making happens. That the patient is aware that there is a decision to be made, what that decision is, and that you as a clinician want to involve the patient actively in helping to make the decision. That there is a process by which unbiased information, and the word unbiased probably ought to be on the slide, about the pros and cons are discussed with the patient. And my guess is that that kind of patient information is what people often do well. I think where we might fall down is in these last two steps, that after we've presented the information, we really need to stop and understand the patient preferences. What's important to them? What are their goals? What are their values in regard to this particular decision? And then once we understand that, to help them make a decision that is most consistent with their preferences and make sure that that decision is carried through. In the case of lung cancer screening, it's easy. The patient either decides that they want to proceed with screening or they don't, and presumably nobody would screen a patient who says, I really don't want to do this. When it comes to another part of care that shared decision-making is important, end-of-life care decisions, that incorporation of what the patient preference is along the continuum so that everybody knows what the patient wants becomes a more challenging part of the process. Next slide, please. So since we cannot observe people in their clinical settings to know whether they're doing shared decision-making or not, this measure, the option 5, is a way for you to even rate yourself, or if you're in a position where somebody else can rate you, or in perhaps asking a patient to rate whether shared decision-making happened or not. You can see really the 5 questions ask about those components that Paul and I have talked about. Did the clinician identify that there are options and that a decision needs to be made? And item 2 is really to assure the patient that they will be helped to understand their options and to participate in the decision. Then there's the information provision item, the elicitation of preferences, and the effort to integrate the preferences into the decision. So you can see that the measures on this tool line up with what we think is required to say that you've done shared decision making. When we teach in a face-to-face setting, we will do role playing and we will have an observer use this as a way to give feedback on how well the shared decision-making conversation went. So this can be useful as you think about your own work and whether you are indeed doing shared decision-making. Next slide, please. So that's the end of our presentation. We wanted to provide some resources. This slide shows you websites where the decision aids, some of the decision aids we've shown you about lung cancer screening, as well as some others that exist out there are available. This is a new and developing field. There are new decision aids being released. So this is probably not all of them anymore. We've looked at all of these and we know these are good quality decision aids. The fifth one down from the University of Michigan is video based, and for some patients, video rather than print might be a preferable option. The next slide, please, are some general websites where you can learn more about shared decision making. So again, these are resources to help you if you want to learn more about this. So that's our presentation for the day. Thank you all for being part of this webinar, and Paul and I are available to answer questions.
Great. And I just want to jump in really quick and let everyone know that we are going to post these slides with those links and everything to the website, and we'll post the recording of today's webinar as well. So it looks like we do have a question. Mark, if you want to chat in your question or put it in the Q&A box, we'll read it out and be able to answer that for you. Let's see if I can. So we have a question, but I don't know, maybe he doesn't have the ability to type in his question. So let's see if I can let him talk here. Hold on just one second. It looks like, Mark, I'm not able to turn on your video function. So if you can either type in a question or you can email me or Jessica, and we'll kind of get to that as quickly as we can for you.
We're happy to answer questions by email even after this hour is done.
Great, thank you. Yeah, and if anyone else has a question, feel free to chat or use the Q&A function. And we do have a Matt now has a question, wondering how much additional time implementing this approach adds to an appointment.
So there have been some studies. I think actually the issue of time is one that was addressed in the most recent Cochrane review. My recollection is that that adding a shared decision-making discussion might add 5 to 7 minutes. I would say substitute, given that I was a PCP for 20 years, you'd have to give up something else that would take 5 to 7 minutes in order to do this instead. There have been studies that have shown almost no impact on the total amount of time, others that have shown more than that. So that 5 to 7 minutes is the best average we can give. Paul, would you add anything?
Yeah, it's clearly going to, I think, at least my experience in looking at the literature, I think it's clearly going to involve more effort. How much time that effort requires, I think, depends on a lot of factors. It depends on your patient. It depends on their level of knowledge. But I think there's going to be some additional time and resources and effort. There's no question about that. The other issue here is that it doesn't have to be accomplished in one visit. You know, and particularly for an elective intervention like a screening intervention, I don't believe this has to happen all in one visit. And it can happen in chunks if it's skillfully done, I think, and feed people small bits of information, return to the conversation. And then we're also exploring the use of decision aids, as Neil talked about, other processes of care where perhaps those can be mailed out to a patient in advance of a visit or during a visit, then it gets talked about at a subsequent visit. So I think there are a lot of models, but I think the commenter is bringing up a really great and important point. We need to figure out how to do this efficiently, and I think we're still.
Yeah.
The other point I would make is, in addition to the fact that it doesn't have to happen all within one visit, the provider, the physician, doesn't have to do all of the work. Well-trained staff members, nurses certainly have been trained to do shared decision making, and probably other members of the team could be as well.
Great. We do have, looks like we have a couple more minutes. We have one more question so far. What if the patient asks you to assess his personal risk to determine participation? For example, a 3-pack a day smoker as opposed to a 1-pack a day smoker.
So actually, that's a really excellent question as well. That's really pointing to a future direction that a lot of people believe in for more intelligent precision screening. And there are now coming online a number of risk prediction models that use information about a patient to provide an individualized estimate of their risk for lung cancer. Now, this isn't guideline-based practice yet, but we actually think this is the direction that the field is moving. And these models, one of them is being put out by the National Cancer Institute later this year. And so these will be available, and we think that this is the future of screening, although it's not yet been codified in guidelines. And we think it's an excellent direction for the future. So, you know, right now our advice is stay tuned. I think this is going to be where the field goes.
I know we're pretty much at time, but right now the criteria for screening are based only on age and personal smoking history, and we know there are other factors such as secondhand smoke and radon that increase risk of lung cancer, but we're not yet able to incorporate those into our risk assessments, and hopefully these more individualized risk calculators, similar to what many of you are using now to help people make decisions about statins for prevention, should be useful to us once they're more available.
Great. We are pretty much right at time. If there are other questions, feel free to email them to us. We are mlcc@mainequalitycounts.org, and we'll make sure to distribute those questions here to Dr. Hahn and Dr. Corson so we can get those out to you. And I'm going to turn it over back to Jess.
Terrific. Thank you so much. Thank you so much, Dr. Hahn, Dr. Corson. Really appreciate you. So your time, excuse me, and really sharing all this great information with us. And again, just to remind people that you'll be able to access the slide deck as well as other webinars that we have done for the MLC. So if you go on the QC website, you will find a link where it says the Maine Lung Cancer Coalition. So please link that, click on that and go down to the bottom, and you'll see where there's Learned Archives, and you can actually access, the series. So we've done multiple webinars at this point, and we definitely encourage you to go there and check out those resources as well. So I would at this time just like to mention our next webinar, which is going to be following up on abnormal low-dose CT screening results with Dr. Gary Hochheiser. He is the medical director for lung cancer screening program at Maine Medical Center. So we are very excited to have him with us and to be talking about this topic at our next webinar, and we hope that you'll all be able to join us at that time. So again, I'm sorry we're a couple minutes over, but just want to take some of your questions. Again, any other questions, please let us know. We're happy to get that information out to you all. And thank you all so much for taking the time to join us today. It's always a pleasure to host all of you, and we hope that you'll come back again for our next webinar. So thank you so much, and enjoy the beautiful day. Thank you again.
Bye-bye.
Bye, everyone.